Hello, good morning, and welcome. My name is Alicia Gonzalez. I am the Director of Clinical Training for the California Bridge Program, and I am joined today by two amazing experts that I am so excited to have on as my guests today, Dr. Andrew Herring and Dr. Tipu V. I will let them each introduce themselves real briefly here. Dr. Herring, can you tell everybody who you are?
Yes, hi. My name is Andrew Herring. I'm an emergency physician and addiction physician at Highland Hospital, and very happy to work with Alicia and Ariana and Amy and all the other amazing people at CA Bridge.
Awesome. And Dr. Khan.
Hey y'all, Tipu Khan. I'm a family physician and addiction specialist over at Ventura County Medical Center, and I am excited to be a part of this panel. Thank you.
Awesome. So we are going today to talk about advanced buprenorphine, as in beyond the 101. But there are a couple of things we want to make sure that you know. First of all, the California Bridge Program is a program of the Public Health Institute. We are funded through a state grant. We are a nonprofit. I want to be very clear. We are going to say brand names today. That is because when we talk about long-acting injectables, there are currently only two medications on the market, and they are different. And to call them both buprenorphine is not going to work for you. So we are going to say brand names, but it has nothing to do with any financial relationship with either of those companies. In case you've never heard of us here at California Bridge, our goal is to make medication for addiction treatment, as an evidence-based treatment for people with addiction, accessible to every person in California by 2025. I know that's next year, but we are well on our way. We are at over 270 hospitals here in California, and we've definitely started to increase our national blueprint as well in helping hospitals do this work. What the California Bridge model looks like is focusing on low barrier access to treatment, meeting patients where they're at, which means often in the emergency department or in the hospital, getting that medication available to them and making sure all of our teams are ready to start those meds. But as with anything we do in the acute care setting, we really want to make sure we are doing a good job of resuscitating in that moment, stabilizing in that moment, but connecting that patient to ongoing care in the community. And that involves having navigators or at least clear pathways to get our patients to follow-up care. And then finally, building a culture of harm reduction. This means, number one, decreasing the stigma that has for a very long time been held against patients who use drugs, but also helping us talk to patients better about how to not die, how to not have worse morbidity and mortality associated with drug use. For today, we are focusing on low barrier access to treatment. And when we say treatment at Bridge, we mean medication. Okay, medication is treatment for opioid use disorder. Why do we focus so much on medication? Well, in case you're new to this work with us, it's because we know it saves lives. The average person out there who is using opioids has a 6 times likelihood of death compared to a person who is not. However, if you start that patient, if that person starts medication, specifically buprenorphine or methadone, their risk of death comes down to less than 2 times that of the general population. That is going from 6 times likelihood of death to closer to that of the normal population, which means that's a massive mortality reduction. Massive. Name me another medication that decreases your mortality this well. I bet you can't do it. And so we know that it's life-saving. Said differently, it only takes 2 patients started on medication for addiction treatment for opioid use disorder on buprenorphine, 2 of them, to keep them in treatment. And since I just showed you that treatment is mortality reducing, this means saving lives. Compare that to the number needed to treat for other things that we consider standard of care. I mean, this is like massively impactful, really solid evidence, very safe. And so we want to make sure that we know what we're doing and we're starting patients on this medicine. I'm going to breeze through a couple of things about bup really fast, again, just to level set and make sure we're all on the same page. We're going to talk about buprenorphine a lot. It's not meant to diss other medications. Like, we support methadone. Methadone is a really important medication for addiction treatment. It will be the right medicine for some patients. But for us, we like buprenorphine because of several practical and safety profile reasons. Bup is a partial agonist, meaning it does not turn that mu opioid receptor all the way on. It only partially activates it. The goal is not to go from normal to euphoria or to getting high. The goal is to get out of withdrawal, out of cravings, into feeling normal, into saturating enough of those opioid receptors that somebody whose body has developed physical dependence on opioid can function normally. We like it also because as a partial agonist, it has a well-documented ceiling on respiratory depression. That means buprenorphine all by itself isn't going to cause you to stop breathing, to go into respiratory arrest. It has a very high affinity for the opioid receptor, meaning if you have bup in your system and you were to say use fentanyl or another full agonist opioid, that buprenorphine is not going to let go of the receptors that it's occupying, which helps to prevent against overdose. It treats cravings, it treats withdrawal, it helps our patients to normalize their brain, to find like a new homeostasis and a new normal, which is amazing for them. It has a really nice long half-life of 24 to 36 hours in the oral formulation, which means a lot of patients can be on 1 or 2 times a day dosing. They can have a prescription at home. They don't have to go to a quote methadone clinic or an opioid treatment facility to get their daily dose. So it's really practical for us. This is all for the oral formulation. The pharmacokinetic properties of buprenorphine are going to be the same for the long-acting injectable. For example, the high affinity to the receptor and the partial agonism, the ceiling effect on respiratory depression, all that stays the same, but that half-life is going to be different. If you need more than this, please go watch our Bup 101 video, okay? That video is about a half an hour long. It goes into great detail about how to start patients on buprenorphine when they are in opioid withdrawal. What that kind of looks like is first, you see a patient who's actively in withdrawal. You can start them immediately on oral buprenorphine. It's dissolvable in the mouth. We recommend 16 to somewhere around 24 or 32 milligrams, depending on the patient's tolerance, but at least 16 milligrams. You wait a little bit and make sure they're getting better, that you're not missing something, that it's not alcohol withdrawal or sepsis or something like that. And if they're getting better, you give them another dose. You fully load them with buprenorphine. And then after that, you send them home with a prescription. That is literally how simple it is. A lot more details in that algorithm are available to you in that Bup 101 video. And then also to know, it's so safe to do this. Patients can literally start themselves on buprenorphine. They don't even need you. They don't need a cardiac monitor or a pulse ox or any of that. They can start themselves on it. And there are ways to help patients who are not yet in withdrawal to start on buprenorphine slowly while you do what's called a cross taper or microdosing or low dose bup as you continue full agonist opioid. We did a full hour-long lecture deep dive on this. So if you're an inpatient doc, a hospitalist, somebody who wants to learn more about that, I invite you to go watch that lecture as well. If you're watching this live, we just put all the links in the chat for all these algorithms. But if that's what you're looking for, please go visit those other lectures, because today we are going to focus on long-acting buprenorphine. So now it is time for me to stop talking and turn it over to our guests, Dr. Khan, Dr. Herring. Tell me everything about these medications. What are they called? How do they work? What are their differences? Tell me everything that I need to know.
Tipu, take it away.
All right. Back me up, Andrew. So, these long-acting injectables are really, really interesting medication, and they're game changers, I think, in the role of buprenorphine management. Just taking it a step back, I think it's important to realize that our patients who take sublingual buprenorphine, whatever product you use, they still have a certain level of bup that they can get their plasma to, and oftentimes it's not enough, and they find themselves still having to use a full agonist, fentanyl, heroin, whatever they're using on board, on top of it. But with these long-acting injectables, we're finding we're getting these higher plasma levels of buprenorphine that are leading to 80, 90% plus mu opiate receptor saturation. What does that mean? In plain words, that means the busier we can keep that mu opiate receptor, the less likely they're going to have withdrawal symptoms and cravings. So we want to occupy that receptor as much as possible with a safe, controlled pharmaceutical medication than them getting their fentanyl and self-medicating. And that's what these do. They get you to a higher plasma bup concentration that allows for better retention and treatment and more access to care. There's 2 big medications out there. I'll start with one and I'll hand over to Andrew to kind of talk about the other one. But the one that we've had for some time now, for a couple of years, has been Sublocade, which is a long-acting depot buprenorphine. Essentially what it is it comes in a little syringe. You inject it in the abdomen. It turns into this gel ball that then slowly dissociates over time, over the course of about a month. Comes in 2 doses. We usually start with a 300 milligram dose, and then we titrate them down to 100 milligrams if desired, or you keep them at the 300 milligram, kind of let them decide what they're going to do. Great medication, saved a lot of lives. Downsides to this medication, though, are that it is not, we do not have human data on safety in pregnancy. A lot of us have used it, but there is teratogenic potential risk in animal modeling data, not from the buprenorphine itself, but from the delivery agent that they use to solidify the medication. So that's something you need to understand and have that risk-benefit discussion with your patients if you're going to use it. It does hurt a little bit more than I think than the other product, and you do have to make sure you really get that sub-Q angle correct. But it works well, and we've been using it for a while with a lot of good outcomes. I'll hand it over to Andrew to talk a little bit about Brixadi.
Sure. Thanks, Tipo. So Brixadi is, the goo that holds Sublocade is called Atrigel. And then for Brixadi, it's liquid crystal. It's basically just the same idea. It's a goo that holds it together so that it creates a ball. And just basically when you look at the weekly or monthly dosing, there's no other difference other than just the size of the ball. So a little ball is a week. A big ball is a month. You put in 2 of them, that could be 2 months. So we have a colleague, Dr. Azad in Vancouver. He'll give people 2 Sublocades who have really, really heavy use. And he's just putting in a big ball. So the thing to understand is that basically, no matter how big that ball is, it always peaks at about 24 hours. So the slope to the peak is just going to get steeper and steeper and steeper the more you put in.
Yeah, so let's talk about that a little bit. So I think you had sent me this image ahead of time, Andrew. How is this going to be different in as far as like reaching its concentrations that we want it to be versus coming down? Like, what does that look like compared to what I'm used to, which is treating with sublingual dissolvable buprenorphine?
Yeah. So there's be interesting to see what Tipo says, but basically there's it's confusing a little bit, but there's 2 things that happen. One is that there's a little bit of a gap, right? So it's not going to come on as fast. So if you're in severe withdrawal, you're not going to feel it as quickly when you give the Sublocade or you give the Brixadi. So often people will give an 16 or 24 for that initial 12 to 24 hours as the levels are rising. But at the same time, it's a much more steady signal of bupe. So it's powerful, whereas a sublingual will come and as soon as it peaks, it's washing out. Whereas these injectables, they just push. And I imagine like a sumo wrestler just pushing. So if you've got like a precipitated withdrawal scenario or just someone's, can't get comfortable on bupe, often they finally get over the hump and feel good when they get onto an injectable. Because it's just this, moment after moment, there's more and more bupe without these little micro spikes.
And so somewhere starting around like the 2-hour mark, starting to feel effects, but giving that oral dose up front to hit that spike a bit earlier, and then it will last in your system how long, depending on the dosing you said, right?
Yeah, it depends on the dose. So the bigger the ball, the longer it lasts. And then they market it as like 7 days, a month, but everyone's really different. There are amazing papers that just show there's the median, and then there's the various outliers, and then there's the actual human data that just pull way out. So you're going to have some people who, and this is one of the problems, is you're going to have some people who get the injection and they feel like they're cured, right? Because it just stays in their system so persistently, and they have no withdrawal. It just gradually washes out. And you kind of got to let them know, like, hey, man, like we didn't just like wave a wand and fix you. And then other people will get that ball and their metabolism will just chew it up. It'll be done. And 2-3 weeks, they're like, man, I'm waking up in cold sweats. And you're like, what? How is that possible? And it is, they're just outliers. There's a lot of variability.
Yeah. And what about starting doses? Like, what does that look like? What's that conversion? I mean, I'm used to really only using the sublingual. So if I wanted to do this, say in the ER or the hospital, how would I know how much to give somebody?
Tipu, what do you think?
Yeah, so Brixadi came out with this nice kind of table that's in their PI, which we've got up here on the screen, which I think is a great kind of overall conversion to start with. And most people, taking a step back to pharmacokinetics, we know most people to get decent opiate receptor saturation, again, to keep that receptor busy enough that they're stable, they're going to need at least a 12 to 16 milligram dose. So most people are going to fall into this like 24 milligrams of weekly versus 96 of monthly. Now, how do you choose between the two? It really, I keep it patient dependent. Some patients are trying to kind of figure out where they're going with their buprenorphine management. They're not convinced they want a long-term treatment yet. And of course, you're going to educate them on disease state, et cetera, to get them there. But there are definitely some patients that I found weekly just works better because they're still trying to figure out what dose they want to be on, et cetera. But for the most part, I try to shoot for monthly as best as possible using kind of this algorithm. With Sublocade, we have a bit more of a kind of a strict algorithm because your starting dose is per FDA labeling is 300 milligrams. So we want people on at least 8 milligrams a day for a week. That's what we're taught. That's what's on the labeling, etc. Now, again, those of us that have been doing this for a while, and as you practice and do this in your own practice more and more, you'll find that we can start this sooner and use it more at lower doses and adjust the dosing there. But again, that's not on FDA labeling. So you just need to understand, you need to make a clinical decision on how you want to use that medication. But I find that for most people, getting that big dose ahead of time early, getting that 300 of Sublocade, or at least that 96 milligram of Brixadi, helps them get this peak plasma level and slowly drop that over the course of the time frame of the medication. So as we see on this slide, looking at Brixadi, we see that we get that initial peak over the first time frame, the first 8 to 12 hours of plasma buprenorphine, and then it slowly kind of tapers and settles down versus that peak trough with sublingual that we want to avoid. Because when we think in general of peak and trough, peak is I feel good, I don't need to use any drugs, I'm doing okay. Trough is I'm now in opiate deficit and I've got that negative reinforcement and negative affect I need to deal with, meaning I don't want to get sick, I'm starting to withdraw, I want to feel better. And we want to avoid this trough as much as we can because that's what's going to increase the risk of course, use and death again. So we want to get that peak to a stable level as much as possible. And we see that happens both here in Brixadi, but also on the next slide with Sublocade as time goes on over that course of the month. But I think it's really important, like Andrew had mentioned, that everyone's physiology is a little different. And there are some patients that both with Brixadi and Sublocade are going to be fine with just your injection. But a lot of them are going to need, especially in that first couple months while they're getting to a good steady state and figuring out what dose they need, some sublingual support. So I think it is the standard of care that we should be giving every patient who gets a long-acting injectable a prescription for sublingual bup as well. And
Yeah,
that's going to be something they can kind of use as needed throughout the month.
yeah, that was a question that came up in the chat actually that I just want to highlight. So, the question being if you give it to the patient, they feel good initially, say you're doing a month-long version of this. What do you do if 2 or 3 weeks into their 4-week treatment, they're starting to have more symptoms again? Do you recommend increasing the frequency of the injection, or do you simply make sure they have enough oral bup for their breakthrough?
Yeah, that's a good question. And in our practice, what we do, because where we practice at, we don't have access to getting these medications covered before a month. It's difficult with our Medi-Cal, unfortunately. So we try to keep it all within 1 month injections. We can get it in about 3 weeks, so we can kind of pull that off. But I do think that that's a great idea. You can definitely do, as Andrew was mentioning, multiple injections. You can just dose it sooner, give it at the 2-3 week mark if they need that. However, insurance coverage tends to be an issue for that. So I think what most of us do is we go with sublingual, is we get them a sublingual prescription and tell them to use it as needed. My typical prescription for that is buprenorphine, naloxone, or buprenorphine film, either way, or tab, 4 milligrams, use TID as needed for withdrawal symptoms, and give them 30 a month and say, hey, if this doesn't work and you need more, just give me a holler. But that will get most patients kind of through. The one caveat I will add, though, just real quick, and you led with this, Alicia, was that buprenorphine is not a cure-all for everybody, right? Some people are gonna need a full agonist. So you want to also keep that in the back of your mind that although buprenorphine has made the treatment of opiate use disorder accessible to all of us in all of our specialties, we do need to remember there's some people that just may not be doing well with this, including on sublingual, maybe even a higher dose of long-acting injectable. Keep methadone in the back of your mind still for some patients. They may need that escalation. Thoughts,
Yeah,
Andrew?
and actually, I see some questions in the chat popping up about insurance and coverage. We'll jump to that in a second, but I want to first dive into what you just said. I think a good question for us, Dr. Khan, is like, who are the right patients? Like, how do I pick which patients might be the right patients for long-acting injectables versus not? Like, what does that thought process look like for you?
Yeah, so I'll give you my quick 2 cents on how I approach it in my practice and then hand it back over to Andrew for kind of how he does it. But I really do think, and we had talked about this earlier when we were prepping for this, but I really do think every patient who's buprenorphine eligible is a good patient for long-acting injectable, right? You remove the whole oral fixation part that they need to take something every day, this peak trough we talked about, the whole dependency and the psychological aspect of having to use something multiple times a day. You normalize that into, hey, this is disease state of addiction, just like your diabetes med you take every day or your high blood pressure med you take every day. Here's one thing you take that lasts for a long period of time. I think it works great for them. The other population we use it a lot for as a county hospital are our patients that are struggling with homelessness, where they can get their meds stolen. They don't have access to meds regularly. We really kind of push those, well, offer that medication to them. And then the third population I think we really focus on a lot, again, as a county-based facility, is patients who are trying to go to nursing facilities or to sober livings. A lot of sober living still aren't on board with patients having sublingual because of the risk of diversion, or also philosophical of how they approach it. But most of them I've interacted with are okay with an injectable that can't be diverted. So that's another population we really try to get it to.
I love that as a dispo support, right? Like if the oral formulation is not working for pharmacy or other reasons, that would be convenient. Andrew, are there any patients that are not good candidates for a long-acting injectable? Like, how would you decide someone's not the right patient?
Yeah, I mean, in general, I mean, I totally agree with Tipu here in that, because the injectable is a little bit more of a pain. You've got the insurance you got to work through, you've got to do the injection versus just doing a prescription. You got to always be aware there's going to be a subtle kind of inclination for the team to forget about it or not do it. So there's kind of like always this course correction for your team is like, hey, our goal is that every single person should be on Brixadi or Sublocade. Now, they may not want it. They may not want to come in. They might not have insurance that covers it. It might make a bump that they don't like. They might not like needles. That's fine. But like the team goal should always be kind of getting people pumped, because I think we all believe it just works better, particularly for this crucial period after you meet them in the ER. So the one thing that I have seen is that at these higher levels of buprenorphine, some people can get confused. So when you have this steady state of buprenorphine, some people might have this residual kind of ickiness that has to do with just basically their body getting used to buprenorphine, maybe a little bit of nausea from it, and they can interpret that as withdrawal. So I have seen people insist, like absolutely insist, on 32 milligrams of buprenorphine on top of their Sublocade. And I knew that they didn't have a heavy use history. And I'm like, I just don't think you're in withdrawal. And they were like, if you don't give it to me, I'm just gonna get it from my friend. This kind of stuff. And so we went through like months of this, and then finally that person who really was on 300 milligrams of Sublocade and 32 a day ended up getting comfortable and happy on 8 milligrams of buprenorphine a day. So he just got all confused. So that's one thing, is that just know that. And then if you have somebody who's taking like 4 Norco-10s a day, that person, it might be just too much. So the 300 of Sublocade would be too much. They would be perfect for the lower doses of Brixadi.
Ah, okay.
Right.
Cool.
So that's really neat, because that's definitely, I had one person who basically I'd been prescribing them 8 milligrams 3 times a day, but I think there's like one for me, one for my buddy, those kind of things. So then when we actually gave the injection, she basically had this wicked migraine all weekend, right? Because that's what it feels like when you're overdosed, quote unquote, with buprenorphine. It kind of just feels like a migraine. You have headache, nausea, and all that stuff. So it's not like they stop breathing or anything, but it's just unpleasant and unnecessary. So
Yeah. That's actually one of the questions Dr. Nicole Woytal, one of our implementation leaders at Bridge, she asked us, what does it look like for someone to, quote, fail a long-acting injectable, like somebody who tried it and it's not the right thing for them? How do you know that? It sounds like perhaps if they are really only needing very low dosing and the long-acting injectable is more than they needed, that's one version. What might look like that?
I guess what I've seen is just people, Brixadi appear. I mean, interested to see what Tipo thinks, but it appears that the Brixadi is much better for forming lumps. But some people really do form pretty big lumps with Sublocade, and they don't like it. So that's been the main thing, is just they get sick of the needle stuff. They think they're cured. They don't like the bumps. Those have been the things I've seen.
Yeah.
Yeah, I agree. Second that, especially with the lump, a lot of people really are just not excited about, because that lump takes a while to go away. Even though the medication may not be active, that gel lump is still kind of there, and we rotate quadrants, and it still can be bothersome. But I think the other thing to kind of keep an eye out for with failure is, again, going back to just, this is a partial agonist in the end, right? And some patients' physiology and use disorder may just benefit from a full agonist. So some of the failures I see with the long-acting injectables are they're on a good dose. They're on 128 of Brixadi or 300 of Sublocade, and they've got Bup on top, but they're still, using fentanyl. And the bottom line is they may just need a full agonist. So again, I think just kind of putting all that together and individualizing that care and meeting patients where they're at is going to be important.
Yeah.
Yeah, that's great. So now I want to ask the question that came up before about insurance coverage and payment. I mean, this is like always how we feel about new drugs, right? Especially injectables. Like we've all been there with the long-acting naltrexone and stuff like that, like thinking about how to do these. What do these medicines cost? And, are they covered by Medicaid? I guess for a lot of us, specifically Medi-Cal, but in general, what's that coverage look like? And let's maybe start by talking about the emergency department specifically, and then separately inpatient and then outpatient. I would love to kind of know those three buckets. So first, emergency department. What does that coverage look like from the ER? Is this covered? Is it like really expensive? What's that look like?
So Tipu, I mean, in California, it's going to be, well, I guess it depends on where you are, right? So I'm in a county hospital. So for us, it's bundled. So we're not going to be able to line item bill Brixadi. It's covered completely as an outpatient, but when it's given on the inpatient, it's bundled. So that basically the hospital has to eat it.
Got it.
Yeah. Yeah, agreed. I mean, if you're not Medi-Cal and you're fee for service, then the hospital can bill for it. So you can buy and bill where your pharmacy stores it, and then you can bill for the medication. And these meds aren't cheap. They're anywhere between, depending on what pricing structure you get, $900 to $1,200 for these. But they work. So you may want to think about that when you talk to your P&T committees, et cetera, about getting it covered. Same thing for the inpatient standpoint. Most inpatients, especially with Medi-Cal, you're getting a bundled DRG, a daily rate essentially. So the hospital does kind of eat the cost. When we instituted this as an inpatient, one of the selling points we had to our P&T committee, because that came up, they said, well, who's going to pay for this medication? Again, we're a county hospital. We're kind of just floating in a neutral position. How do we not lose money if we're going to add this new medication in? And the sell for it was, hey, look, we've got these patients that are sitting here for 3, 4, 5 extra days waiting to get dispoed somewhere, and we can't find anywhere to dispo them. Or they've got endocarditis and they're on antibiotics for a couple of weeks, but the nursing facility can't take them because they can't manage their Bup or whatever. If I can get injectable in, we've just reduced their amount of stay here, and the total cost our hospital loses on unplaceable patients. And so that was a sell for the inpatient standpoint. Now with private insurances, of course, your HMOs and PPOs, you can negotiate that with them and a line item bill for buprenorphine long-acting injectables. So that is something to keep in the back of your mind. From an outpatient standpoint, at least for Medi-Cal, it is covered as a carve-out through Medi-Cal. So most of the time what we do is we just use a specialty pharmacy, we order it, have it delivered to us, and we inject it. It doesn't go to the patient, it has to come to us, of course, to your office. You can also buy and bill, which Medi-Cal does reimburse for in your clinic. So you can buy this, stock it yourself, and just bill Medi-Cal or private insurance retroactively after you give it to them.
Yeah. So then, I mean, generally speaking, it sounds like in some cases it'll be covered, which is great. In other cases, maybe not. But it sounds like you're both doing it in your hospitals anyway. And like I know, Tipu, you mentioned you're at a county facility. So I want to emphasize, obviously, your hospital has found this to be valuable enough for other reasons that it's worth the cost, which I think it's like $1,000 and something, right? Like it's the cost. So can you talk a little bit about that? Like if you're somebody trying to get this instituted in your hospital and your hospital's like, oh my God, it's $1,000 and I can't promise it's going to get paid for. No way. What's that conversation? Like, what are some of those endpoints that maybe do show financial value? Obviously we care most about saving lives, but I have to respect that hospitals have budgets. What are some of those talking points that you can use?
Yeah, every hospital is different. So we'll see what Andrew says about his institution. I know for ours, philosophically, our administration was on board of, this is the patient population we see. We've got to do something to save their life. But they were stuck on that. Well, what do we do with this $1,000 medication? And again, I framed it from the dispo standpoint, and that, we lose money. Like if we have patients that are unplaceable, we're not getting paid anymore for them to be here. So we're actually eating that cost. So this is cheaper than a daily bed rate in our hospital. But the other thing I think we looked at was quality adjusted life years with the total reduction in return visits, recidivism rates in our ER, in our inpatient unit, et cetera. And so that really, I think, made an impact in helping them understand, well, we're going to reduce the amount of patients that have to come back to the ER because they got an abscess, a cellulitis, they overdosed, whatever it is, and then get admitted and whatnot. And I think that was a big sell. But I would definitely recommend finding those key stakeholders in your P&T committee, in your finance committee, who you can lean on to help advocate for you as you push that through. How about you, Andrew? How about your hospital?
Yeah, I think similarly there was certainly a certain level of trust in our team. You know, we believed really strongly in it. Um, and then some of the most compelling data that we're seeing is for admitted patients. If you have a serious OUD and you're admitted, the chances that you're going to convert that patient to a patient who's stable on buprenorphine without Brixadi, without Sublocade, are really quite low. And there was general med staff agreement. The trauma surgeons, or the regular, other surgeons, internal medicine, they all recognized that there was this clear pattern of discharge and repeat admission. And with the long-acting injectables, the follow-up rate is really, really transformed. It goes from like 10% to 80%. It's really big difference. So many of these cost effectiveness arguments, I think sometimes they're a little flimsy, and that you really have to do what Tipu was talking about, quality of life, survival, like these are the things that really matter. But in this case, specifically for the admitted patient, I think that the long actings really do save money.
Yeah, that makes a lot of sense, especially when we think about things like AMAs and elopements and, which we all know anecdotally, but also evidence has shown our patients with substance use issues are much higher likelihood of having those happen to them. And certainly the hospital loses money on that, right? When the person leaves and comes back and leaves and comes back, it's not good care, which is the most important thing. But it's also certainly not effective from a financial perspective to keep starting over. I want to ask, there are a couple of questions about this in the chat, so I think it's a good time to bring it up. For me as an emergency department doc, like what does this practically look like? And Andrew, I know you do this at Highland, and I actually took the liberty, I hope it's okay, of stealing a
Yeah.
screenshot of your protocol that you guys use, and I have it here on my screen to share with everyone. But how do I do this? So I'm in the emergency department, I have a patient, they're in withdrawal, and I'm thinking like, wow, this would be a great candidate for long acting. Oh, what do I do? What are the steps? Like, pretend I have access to the medicine. We're going to put that part aside. Like, what is the functional, clinical, the ordering? What do I do? How do I do that?
Yeah, ER docs should absolutely love this medicine. It's perfect for us because it enables you to just push a single button, and it's going to last a week or a month, and you can just kind of be done. And so what we've really moved to is an incredibly flexible and liberal strategy. Meaning this was 1.0. This is years old now. We're now basically like, if we can get someone to take it, we're going to give it. So we don't necessarily need to do a lead in at all. We certainly don't for the week long. Now we have thousands of patients actually that we've done that through a study. So if someone is in withdrawal, I would just go for it, basically, and just you
Yeah.
try to get as much in as you can, there's really no other contraindications.
And what about, so, I mean, I know when you and I prepped for this, you had mentioned to me that oftentimes we like to give like a solid oral dose. And if they tolerate that, then bam, go right into it. Because there've been like 4 questions already in the chat about what about precipitated withdrawal? Like it's like everybody's favorite question to ask. So can you talk a little bit about that?
Yeah. Yeah. So that honestly makes no sense to like it's so basically the test is tougher. It's the wrong test. So the ability of someone to tolerate 24 milligrams of the tongue or 18 milligrams of the tongue is not really at all. We don't have any idea how that correlates to the ability to tolerate a subcutaneous injection. It's totally speculative. The initial reason that was done was with this idea that perhaps that person would be toxic if you gave them the subcutaneous. So that's what the test dose was for. So in this case, we're just really seeing like, if you have a decent clinical, history, so you know that the person really does, use opioids of any kind of substantial amount, you're okay to give it a long-acting injectable. You might want to give them a sublingual to help them in the early phases if they're in withdrawal. But if they're kind of in this middling withdrawal, you wouldn't want to test dose it. You just want to go straight to it. Now, the thing to know is, that whenever you give buprenorphine, you are kind of, you're jumping on the mechanical bull a little bit, and you don't know what the ride's going to be like. If you've got a long-acting injectable on board, you almost know for sure, and I'll be interested to see what Tipu thinks, is that worst case scenario, you feel kind of terrible, but you get through it. You're basically never gonna get delirious. You're never going to the ICU. You're never, because you've got so much bupe on board. You might not be happy. You might feel crummy, but you're gonna make it through. So there are a growing number of people who just basically give Sublocade or give Brixide to people who are not in withdrawal. They anticipate precipitated withdrawal, and just, if depending on their setting, just dump full agonist on top of it. Hydromorphone or fentanyl, or just sort of grin and bear it. So that's that kind of edge. I'm not recommending you do it. But just know that if you kind of things get confusing and you have a surprising case where you thought someone was withdrawal, they weren't, and they precipitate, have confidence, you're going to be able to treat them through it. I don't know, Tipu?
Yeah, it's interesting because I think going back to that concept of a test dose and then a long-acting injectable, I think I used to do that a lot. I think I got it from the kind of Vivitrol world, right? Like someone is on an opiate use disorder. I want to get them on Vivitrol. Well, let me test those them with Narcan first, and if they look crappy, then no Vivitrol for you, right?
Yeah.
So that Narcan challenge, and I think when the long-actings first came out, I kind of fell into that trap. I was like, well, let me give them a test dose of sublingual, give them 12 or 16, they tolerate it, then they get it. But I think that thinking has evolved, as Andrew was saying, to us realizing that, and again, if we go back to that graph on slide 20 of the pharmacokinetics, sublingual peaks pretty quickly, and yeah, they're going to feel a little bit better right now, or they're going to precipitate in front of you right now if you give them not enough sublingual. But the depot or the long-acting injectable slowly builds up to plasma concentration over 4, 6, 8 hours or more. So they don't have this full-on blown and precipitated withdrawal, because when we think about precipitated withdrawal, what we're saying is partial agonist comes in, knocks full agonist out, and you get sick. This is more of, it kind of builds up like a microinduction, starts occupying receptors slowly over time. And if they've got a ton of full agonists on board, they're going to have a little bit of withdrawal. But like Andrew said, you can manage that with your clonidine, your baclofen, and a little bit of benzo, full agonist, all your standard precipitated withdrawal treatment stuff that's on the bridge algorithm that you all can take a look at later. But that's different than sublingual, where you put them in full on precipitated by giving them either not enough or too little of a dose and precipitating them. So this is really interesting, and I agree. I think this part is evolving, but I find myself now, oftentimes, in the emergency department at least, when patients are coming in post-reversal, overdose, or they just want to get started on MAT, giving them the injectable along with symptomatic treatment to help manage what I'm going to expect is going to be a mild precipitated withdrawal, especially with high-dose fentanyl. It's going to be a mild precipitated withdrawal, but if they're on board, I think we should get it going and just expect to treat a mild precipitated withdrawal for the next day or so.
Yeah, I love that a lot of what you're sharing is doing what we really try to do here at Bridge, which is demystify precipitated withdrawal. I feel like we hear this question so often because there's a nervousness from clinicians that comes from not wanting to cause harm or pain to anybody. But what I'm hearing you say over and over and over is like, it is treatable. It is not that hard to treat precipitated withdrawal. Like bupe saves the life. Give extra bupe if you need to, sublingually, or give full agonist, like whatever. The bupe is, has a higher affinity for the receptor. You're going to slowly be almost like elegantly microdosing your patient, right? Like you give that depot shot and it slowly increases concentration while that full agonist comes down. I mean, there really aren't as many drawbacks as opposed to not starting the patient on medication, which absolutely have lots of drawbacks as a life-threatening emergency.
Well, especially with Brixadi, which is what I'm really excited about, is because we've got more dosing options now. So we really can do sophisticated, micro inductions now with Brixadi, where maybe you're giving them, an 8 milligram weekly while they're still getting a full agonist on board to do a micro induction. So more to come on that as we kind of play with it and figure it out. But that's where I really see the dosing regimen of Brixadi being useful, especially in the outpatient setting where micro inductions are tough, right? We haven't found perfect algorithms yet to do it. is potentially giving them a Brixadi 8 milligrams while we titrate up some sublingual along with some full agonist or whatever they need to get over their symptoms, with the goal of a monthly, hopefully after 5 or 7 days. So again, more to come on that.
Yeah.
Yeah, I think that's really smart.
And then another question that sort of, when we were prepping for today, we talked about, and I just want to give a nod to it, is the buprenorphine patch. We don't talk a lot about the bup patch for different reasons, I think, but I would love to just make sure that within this advanced bup lecture, we at least kind of nod to it. Talk to me a little bit about the patch. Like, what is the dosing on it? What settings might that be helpful? I don't anticipate me in the ER necessarily using it, but tell me a little bit about it. When is it helpful? What's a good use for that? What's that look like?
Yeah, I'll jump in. We use a lot of patches. They're really actually pretty amazing. I'm just going to avoid all the insurance issues, but let's say you've got them. So there's the biggest patch you could use is a 20 microgram patch. And so for these, you can use it either as a stacking, kind of escalating up titration, where you put on 2 patches and in a couple days, 2 more patches, that kind of thing. You can also use it what we call micro macro, where you put on 1 patch, 2 patch, 3 patch, 4 patch. We don't really know. And then you just let that go, and that becomes kind of this base that they withdrawal down onto. It kind of gets the process going. We don't, maybe it starts triggering some of this receptor recovery that you need to have for buprenorphine to really work. They do that for 24 hours, and then you come on with your 16 or 24 of buprenorphine. I personally, I think that's probably what I would do. If I were going to start bup, then there is this upper range that people should know, that the FDA limit on the 20 micrograms per hour has to do with just because they were checking QTs during the trials. It doesn't make any rational sense, right? The drug is the same. I mean, we're talking about giving 300 milligrams of a month-long dose. That is tremendously more buprenorphine than you're ever going to give in a patch. So it seems outlandish, but you can use many. So in Europe and Canada, we have a colleague, Puya Azar. His strategy for the overlapping induction or the low dose induction with opioid continuation is he puts on 6 patches. And then in 24 hours, he puts on 6 more. And that is equivalent of 0.5 milligrams sublingual every 3 hours for the first 8 hours, and then 1 milligram every 3 hours for another 24 hours. So there's a whole world to play with the patches, which is, a lot there. So that's kind of a quick overview. I think the take home would be, I see somebody who's not yet in withdrawal. I want to psychologically, pharmacologically, clinically initiate this momentum. Put on 2 20 microgram patches, and then do your regular induction.
Awesome. And then another question that came up, and then I'm going to do a quick recap of high yield points, and we'll open it to more questions from the audience. So please, if you have them, toss them in. This is your time. Toss them in the chat. What about pain? There have actually been a couple of questions in here. Number 1, can you use long-acting injectables to treat pain? But number 2, and maybe most importantly, what do we need to know or think about in the emergency department or the hospital setting if a patient has Brixadi or Sublocade on board? They're already using a long-acting injectable buprenorphine as their treatment option, and then they break their leg, or they have a heart attack, or they've got cellulitis, or they have an abscess, or they're going to surgery for their appendix or whatever. What do I need to know in those contexts? What should I do differently? What should I keep in mind? Maybe Tipu will start with you, since
Yeah,
maybe
sure.
a lot of these consults.
Yeah, I think to start with, excuse me, the thing to remember there, of course, is that these patients are not opiate naive, right? They've got buprenorphine on board. Oftentimes, they still have a full agonist that they've been using on board, no matter how you're giving them buprenorphine, long-acting or sublingual. And so treat their pain, right? Get their pain control. Give them a full agonist. Oftentimes, we're going to use a full agonist at a dose higher than what we're used to. So rather than 50 mics of fentanyl every 30 minutes, we might be doing 100 every 30 minutes, right? Maybe a higher dose of fentanyl, maybe a fentanyl drip for a polytrauma. A PCA, et cetera, hydromorphone. So I think the bottom line is, I think a drug that's going to have high mu opiate receptor affinity, and that's not going to be morphine. 4 and 4 morphine, right, is not going to get you anywhere in these patients. You have a polytrauma that's on a long-acting, or that's got a patch on, or just take sublingual, or methadone for that matter comes in, or just fentanyl, right? Any opiate. They are going to be opiate deficient by the time they're there, and they need higher saturation. So reach for fentanyl hydromorphone, a full agonist with high affinity at a higher dose than you used to. Think about a PCA. And then if it's acute pain, think about other pain regimens like ketamine, right? I mean, this is a great opportunity to use ketamine for acute pain management while you manage what's going on in front of you. But keep their sublingual going or their long-acting injectable going. There's a couple times where you may want to actually hold it, but those are kind of, I think, far and few between. For the most part, think of this as their basal insulin. They still need their basal insulin on board. Keep their basal medication
That's
going
great. I
and
love it.
bolus it with some full agonist kind of as needed.
That was an amazing comparison that I'm going to steal next time I explain this to anybody. I mean, I'm going to use the basal insulin example. It's such a really easy and direct comparison. But I do just want to echo really quick. One of the biggest take home points there is like, do not be afraid to treat people's pain. Like it is okay to give full agonists on top of buprenorphine. And that's a really important concept.
Yeah. Yeah. And that, thankfully 5 years ago, this was really quite a contentious debate. But now as of 2021, the American Society of Regional Anesthesia and Pain Medicine, the American Society of Addiction Medicine, the American Society of Anesthesiologists, all of their board of directors came together and produced a consensus guideline, which is very clear. Keep them on their bupe and do exactly what Tipu said. Add
Yeah.
on additional full agonist, use ketamine to potentiate the whole system, utilize regional anesthesia, gabapentinoids when appropriate, etc. So that's if that comes up with your anesthesiologist, you can just Google that and it'll help you.
And send it to them. Yeah.
Yeah.
I love sending people their own consensus statements. It's one of my favorite.
Yeah.
I want to recap a couple of high yield points and then we'll open it to any other questions that are remaining. But so if you are new to this, like honestly, like I am as an emergency doctor or any kind of doctor, here are some things to know about the long-acting injectables. Again, we do not endorse any specific products, but I want to emphasize these are just the two that are out there on the market, two forms of long-acting injectable. You've got your Brixadi and you've got Sublocade. The cool thing about Brixadi is it has both weekly and monthly injections available, and the actual injector is a bit more functionally easy to use and a smaller volume, so patients tend to have a little bit less pain. Sublocade forms a gel ball, is a month long, and sometimes patients have some pain with that injection, but there are plenty of ways to mitigate that with ice packs, et cetera. So it's still a really important and good medication. We don't want to knock either brand. These are amazing options for our patients. They're both going to be given as a subcutaneous depot injection. The plasma concentration will start to rise somewhere around 2 hours, but it takes some time to peak. And then as you saw in those multiple graphs, it slowly falls. So it's really important to give patients an oral dose of buprenorphine up front while they're in that rise period, because they're not going to hit that peak, soon enough to feel relief right away. So don't be afraid to give bupe in the early parts. But also later on, as that level is falling, they're going to need breakthrough buprenorphine oral as well. And it's possible that you might have accidentally underdosed and the patient will need breakthrough for their cravings or their symptoms in the middle too. So write, that month-long prescription of oral buprenorphine dissolvable to help on top of that. It is safe to do. It's not going to cause overdose. You've got a ceiling on respiratory depression there, but it's make sure that you're really helping patients, to achieve the appropriate dosing throughout that rise and fall. You can convert from patients who are already on sublingual into an injection, or as was mentioned, you can totally do a long-acting injectable as a brand new buprenorphine start. It is safe to do this in the emergency department, in the hospital, in the clinic. It can be very expensive out of pocket, but it is covered by Medicaid and in particular by Medi-Cal here in California. So we can help if you need more information about that, email us and we can get that done with you. But the most important take-home point here is this is an amazing option that prevents overdose and saves lives. MAT saves lives. There's incredible evidence for this. And so whatever that looks like, whatever the right way is for our patients, whether it's long acting, so they don't have to worry about going to the pharmacy, maybe they're unhoused, maybe they can't go to their SNF if they have oral buprenorphine, whatever it is, this is another amazing tool in our arsenal to combat the opioid epidemic in our country. If you're looking for any of the resources we reviewed, please head to the California Bridge or the Bridge in general website. We've got all these in beautiful downloadable color copies, for you and all of your colleagues. If you had other questions, there were lots of questions in the chat about precipitated withdrawal, about methadone. We have full dedicated lectures to those topics available for free CME for you by our amazing California Bridge educators. Please head to the California Bridge Academy to watch those and get your free CME certificates. This will help you to meet that national DEA 8-hour requirement also for free. So head over there and get deeper dives into those topics. If we don't have time to address your question, or you want a follow-up phone call from one of our experts to talk about your specific concerns or your the ways that you're thinking about things, email us info@bridge2treatment.org, and we are super happy to have one of our leaders get back to you. So with that, I will just check and see if there are any other questions that we didn't have time to address. Can you view this webinar in the future? Of course you can. Anytime. It'll be on YouTube, and it'll also be on the California Bridge Academy. So we'd love to see you. You can fall asleep to us at night if you want the sounds of our lovely voices talking about buprenorphine. And I'll just pause here and see if there's any other questions, but one each. First, Andrew, anything else we didn't say about long-hanging injectables in general that you'd want to add to this conversation before we are gone for good for today?
Kim, did we say so the Brixadi is much less painful? So it's a really difference. It's like a couple mLs for Sublocade, which really stings, versus literally like 0.6 or 0.3 mLs for Brixadi. So that's a really big advantage.
Awesome. Dr. Khan, any other closing thoughts?
Yeah, the only other thing I would add is that I think there's a lot of potential for these also for patients who want to taper off. Of course, we
Oh,
recommend
thanks.
disease model treatment, right? This is a long-term medication. Keep it as long as you need, your whole life, whatever. But there's going to be patients that are going to want to come off of it. And it's always a little tricky with sublingual, but these long-acting injectables are great. They taper over months. There are studies that have shown that 6 months after last injection, they're still being positive for buprenorphine, right? So it's still in their system. So it's like this auto taper that works beautifully. And for the patients who want to taper, I've had no easier way to taper off buprenorphine than this. And I actually start people on long-acting just because they want to taper off their films. I'll say, well, you want to come off your films? Let's get you on a long-acting for 3 months or so, get you to stability, and then we'll just stop it, and it'll auto taper. And a little bit of rebound anxiety, and that's kind of it. Get an SSRI started, etc., and they do wonderfully. So even patients who don't want to be on it long-term, this is a great option for them to do a painless auto taper.
Yeah.
Awesome. That's a really good call out, right? Every patient is unique, and some patients will want to come off of their buprenorphine. So it's a really elegant way to do that and leave it in their system for a very long time, right? As they gradually come down on it. There are a couple more questions in the chat about cost, and I think that's worth giving it another beat, especially for all of our acute care teams. So I'm gonna highlight a couple of things that we had in our notes, and then I'll open it back up to both of you to just make sure that we've covered it all. So to clarify, from the emergency department, usually we do line item billing, fee for service. So that medication, let's say you give Brixadi, hypothetically, you'd be able to bill for that. And yes, it is covered by Medi-Cal specifically, but also most states by Medicaid. It's just that some states don't have Medicaid expansion. And so not all of our patients have access to that. But certainly here in California, they do. The problem is that I shouldn't say problem. The challenge is that in some emergency departments, you might have an agreement with your Medi-Cal provider or your Medicaid provider. In California, a good example of, like, say, Molina. Maybe you have an agreement with Molina that capitates your care. Like you have an actual, number of lives rate. So when you see a patient, they give you X amount of money, whether it's a pediatric fever that got Tylenol and went home, or whether it's a patient with opioid use disorder and withdrawal who gets Brixadi and an abscess drainage, where you get the same amount for each of those patients. And so in those cases, it's not going to feel like that medication got fully covered. Again, we talked about like the explaining to your hospital, there are definitely cost savings, not to mention life-saving effects of this medication, which is always the most important thing. But, that's one way. But if you don't have that capitated agreement, and your Medi-Cal or your Medicaid provider is paying fee for service, then yes, it would be covered without a pre-auth from the emergency department. The same thing is going to be true on the inpatient side. So if you have like a DRG or like daily rate that is set for that patient, you're going to be eating some of the cost of these injectables. If you don't have that agreement, or if it's a private payer, then you can bill for that medication. So it's just going to be kind of the buy and bill formulation. Your hospital buys the medicine, they have it, then you bill for it once you've administered it. And then the same thing is going to be true in the outpatient setting. So hopefully that helped. I'll open it here. Any other comments on costs or covering the payments? I know it's a big deal for a lot of our facilities.
It's just the other thing is remember, at least from the outpatient standpoint, if you have patients that are uninsured or underinsured, both pharmaceutical companies do offer a patient assistance program where they will cover the gap if there's a large copay, et cetera. So reach out to the company if you need help with copay and whatnot.
Yeah, especially if you're not in California. I noticed when I was prepping for today that both websites actually have a link where you can like work with them to get the medication covered or at least significantly discounted for patients who do not have insurance at all. So for example, if you're not in a Medicaid expansion state and you have a lot of patients that are just plain uninsured, there are options to help reduce that cost from $1,000 down to like 40 or something that might be more tolerable, depending. And then I noticed this coming in there too. Dr. Nene coming to us from El Centro. We know Dr. Nene, he's an amazing champion out there, but mentions, how's the conversation go with PNT? Do you ever talk about like just one population of patients? Specifically in this case, he asks, what about ED only patients, meaning patients who are not going to get admitted? Is there a way to approach it with like, is there a benefit to approaching that conversation that way? Like, hey, we understand it doesn't get paid for inpatient all the time. We just set it up for this grouping of patients. Do you have any thoughts about that or advice about that conversation with PNT?
Yeah, this is where the 7-day injectable is particularly advantageous. Is there's no better way to find somebody in the ER and get them stuck into outpatient care than with the 7-day. It takes away all of the labor to do with prescriptions and all of the bounce backs because it went to the wrong pharmacy and etc. And really gives you a realistic pathway for your outpatient partner to grab that person and pull them into care. So that, we're about to finish a gigantic 2,000 patient study on this from NIDA. The results look great. This is a no-brainer for your PNT. If you're kind of leaning into that kind of negative idea of getting people out of your ED, this is the pathway.
Yeah. And if you need advice on ways to prep that conversation, reach out to us, info@bridge2treatment.org. We love having one of our implementation leaders meet with you to prep that conversation for your PNT or Pharmacy and Therapeutics Committee in your hospital. That's what we're here for. So please reach out to us anytime, info@cabridge.org. All right, that is basically time. We're going to give everyone 60 seconds of their life back. But I really just want to give a massive shout out and a thank you to both Dr. Andrew Herring and Dr. Tipu V for your time and your excellence and your just passion for this work. I really appreciate you both being here. I know I learned a ton in the process of preparing for today. Hopefully all of you who attended did as well. And I also just want to end, as we always do, but by thanking every single one of you who was here for the time that you are putting into this, the work that you are putting into this to help us save lives. Good luck with all your work out there. Reach out to us if you need help and have a wonderful rest of your week.
Thank you. Bye.